Hello, I'm Dr. William McGuire, and I'm a medical oncologist that has specialized for the last many years in the treatment of ovarian cancer. I wanted to spend a few moments today for those of you who have recently been diagnosed with ovarian cancer to tell you a little bit about what to expect in terms of the treatment of the disease. First off, let's talk about standard therapy, and you may have heard about part of this from some of the surgeons that have talked to you. But as a general rule, the initial treatment of ovarian cancer is surgical. And typically following the surgery, except in very, very rare circumstances where it's very early ovarian cancer, you will then begin chemotherapy after you've recovered from the surgery. The goal of that surgery is to remove as much tumor as possible and also to determine how advanced your ovarian cancer is. Optimal surgery should leave behind no single nodule greater than a centimeter. That's about a ½ inch. And obviously the best of all possible worlds would be to leave no visible tumor behind. You're still going to need chemotherapy in the vast majority of situations because if you don't have chemotherapy, there's a very, very high, almost 100% likelihood that that tumor is going to come back. We call this optimal surgery. There are some patients that have suboptimal surgery in which there is one or more tumor nodules left behind that measure greater than a centimeter. That doesn't necessarily mean that your surgeon did improper surgery. There's a fine balance between trying to remove all the tumor but leave the patient as intact as possible, and sometimes it's just not technically feasible to get all of that tumor out. Very occasionally, more in Europe than in the US, but with increasing numbers of patients in the US, when there is a suggestion from scans that removing all of that tumor is going to be extraordinarily difficult, the surgeon may talk to you about having some chemotherapy prior to surgery. That's called neoadjuvant chemotherapy. And so you would get typically about 3 rounds of chemotherapy and then be scheduled for a surgical procedure to go in, again, remove as much tumor as possible, and then get some additional chemotherapy following that. This neoadjuvant chemotherapy oftentimes makes that surgical procedure much easier for the surgeon and therefore easier for you, and also makes it possible sometimes for the surgeon to in fact remove all the tumor that can be seen, whereas he would not be able to do that without having given you some chemotherapy prior to that surgical procedure. Let's talk for just a moment about what is standard chemotherapy, and typically this is 6 treatments with 2 drugs, one called carboplatin, the other called paclitaxel, also known as Taxol, and these are typically given once every 3 weeks. I'll spend a few moments later on telling you about the toxicities of these drugs. There are some recent studies from Japan and from the US that have suggested that giving that Taxol or the paclitaxel in smaller doses each week improves outcome. And this is called dose-dense therapy. So your surgeon or chemotherapist may talk to you about getting dose-dense chemotherapy, in which the carboplatin is still given once every 3 weeks, but the Taxol is given every week. In some patients who have all their tumor removed at surgery, there is occasionally a recommendation from your physician for what is called intraperitoneal chemotherapy, in which some of the chemotherapy is given intravenously, typically in the 2 things that I mentioned before, the standard treatment and the dose-dense treatment. All of those drugs, those 2 drugs, are given intravenously, but occasionally some of those drugs may be given directly into the abdominal cavity through a tube that is inserted into the abdominal cavity, which stays in the abdomen throughout the time you're getting chemotherapy and can then be removed. Intraperitoneal chemotherapy, as it's called, is more toxic, and only about half of the patients who get that treatment are really able to complete all 6 of the treatments. I'll talk a little bit more about the special toxicity that is associated with intraperitoneal chemotherapy in a few moments. If you're not able to get all the treatment, then the doctor would switch you over to all intravenous chemotherapy partway through, again to complete a total of 6 cycles of chemotherapy. Let's talk about the toxicity from chemotherapy. If you get the 2 drugs that I mentioned, which 95+% of patients are going to have recommended, you can expect to have loss of hair, essentially all the hair, and this may include not only scalp hair, but eyebrows, eyelashes, and sometimes even pubic hair. That will start at about 3 weeks, and by the end of the second treatment, or the end of 6 weeks, it's pretty much all out. That's always hard for the patient, but that hair will grow back slowly when the chemotherapy is completed. The second side effect is depression of blood counts. There are 3 cells that we are concerned about: the red blood cells, which carry oxygen, the white blood cells, which fight infection, and platelets, which are small cells that are associated with blood clotting. I'll spend a little bit more time talking about how we address each of these potential problems as I get further into this talk. If the red cell count is too low, you may experience fatigue, you may experience headache, you may experience shortness of breath, and typically if that happens, you can get a transfusion. If the white cell count gets too low, you're at some risk for infection, and so the doctor may give you some oral antibiotics to take for a few days. And rarely does the platelet count, the cells that have to do with blood clotting, get low enough that we're concerned about the potential for excessive bleeding. A third possible side effect is an allergic reaction. This is typically an allergic reaction to the drug Taxol, and you will be given some anti-allergy medications intravenously and sometimes by mouth as well prior to starting that chemotherapy. And these can be mild allergic reactions, a hive, some flushing of the face, all the way to a very serious allergic reaction with shortness of breath, low blood pressure, etc. This only happens in less than 1% of individuals, but it's still important for you to know that that is a possibility. And if you have a severe allergic reaction, there are things that can be done to reduce that possibility on subsequent treatments. I put down nausea and vomiting, although this is actually with the advent of new treatments, some intravenous treatments, some pills that you take by mouth. Nausea and vomiting is really a relatively minor toxicity with this treatment regimen, and I would say that it is actually unusual for a patient to actually vomit. There may be a day or possibly 2 days of very mild nausea and just a sense that you really don't want to eat very much. About 3 days following the treatment, and this is due specifically to the Taxol, you may have the onset of muscle and joint pains. Kind of feels like a bad case of the flu. This occurs in up to 1 out of 5 patients, or possibly 20% of patients. It's usually pretty mild in most patients, but can be really severe, and in a small number of patients is actually the worst toxicity the patient has to deal with. And I'll give you a little bit more data about what can be done to reduce that side effect should you have it. Another side effect is numbness and tingling. That is primarily in the feet, starts in the tips of the toes and begins to move up the foot, and when it gets to about the ankle, you may begin then to experience some numbness and tingling in the tips of the fingers. This is an important toxicity because of all the toxicities that I've mentioned here. This is the one toxicity that may not totally go away once the chemotherapy is over. So you can assume that when the chemotherapy is done, the hair will grow back, the blood counts will return to normal. There are obviously no allergic reactions, the nausea and vomiting goes away, the muscle and joint pains go away. But the numbness and tingling, which we call neuropathy, may actually get worse for up to 3 months after the chemotherapy is over, and then will slowly go away, and in most patients goes away totally, but in a small number of patients there may still be some numbness and tingling lasting for months or even years after the chemotherapy is over. Fever is uncommon. I'll spend a little bit more time about that, but if you develop a fever, and particularly a fever with a low white count, will be the only need to come into the hospital. The rest of this therapy is all basically done as an outpatient. You come into an infusion center, get your treatment, and go home the same day. So only if you develop a fever and a low white count would there be a necessity for a brief admission to the hospital. Fatigue is also reported by many patients. Part of this is just the fatigue that is caused by the chemotherapy. I tell patients that the best treatment for fatigue is actually exercise. And so if you note fatigue, sometimes just getting outside, walking around the block, trying to do a little bit of exercise will actually make that fatigue better. And then lastly, I will mention chemo brain. This is a term that's been coined by many patients for just kind of the inability to for the brain to function normally. People will tend to be forgetful. They tend to say things they wouldn't normally say. This is a direct effect of the chemotherapy and tends to get often more severe as you get further into chemotherapy, and then should slowly go away after the chemotherapy is over. Some other considerations that you should know. I think it's important for you to understand that most women are actually able to carry out normal activities during the therapy. Although those few patients who are having intraperitoneal therapy recommended may need to make some additional trips to the clinic for fluids to combat nausea and vomiting with that particular type of chemotherapy, which is really only recommended for patients in which the surgeon is able to remove all visible tumor and feels that the patient is capable of taking this more toxic therapy. Would this be recommended? But there are now 3 studies which suggest that in that specific group of patients where the surgeon has removed all the tumor, that intraperitoneal therapy probably is a bit more effective than all intravenous therapy. As I've already mentioned, the rare patient may need some red blood cell transfusions, particularly in the last 2 or 3 cycles of chemotherapy. And this is just due to the cumulative effects, the additive effects of multiple doses of chemotherapy, which may have an adverse effect on the body's ability to produce red blood cells. Again, rare patients may develop fever when their white count is low and require a brief hospitalization for intravenous antibiotics. This is actually very uncommon. Less than 2% of patients actually end up needing to be admitted to the hospital for this complication from chemotherapy. And then finally, some doctors may prescribe injections which are given under the skin at home to combat both the low red blood cell count and the white cell count, 2 separate injections. But really these should be avoided if at all possible, because they also have their own set of side effects, particularly bone pain, pain in the hips, pain in the breastbone that can be quite severe. And so current recommendations are that if your red blood cell count is low and you are having symptoms from that low red blood cell count, it's probably actually better to go through a transfusion than to get these injections under the skin. And the separate injection called Neulasta or Neupogen, which is often given by many physicians to combat the low white blood cell count, really is not recommended as a routine practice, but should really only be given in that occasional patient in which the white cell count goes very low and stays down for more than a week, or the very, very rare patient that I've already mentioned that has a low white blood cell count and develops a fever and requires admission to the hospital. Those are the two situations in which giving Neupogen or Neulasta to combat the low white blood cell count should be considered. Finally, I wanted to just mention these occasional patients that have the debilitating muscle cramps. This is less than 5% of patients. Most of the time, if the muscle cramps are severe, and as I've said before, these tend to start about the third day after the chemotherapy, just Tylenol is adequate to take care of those cramps. Should never take aspirin while you're on chemotherapy because it has an adverse effect on the platelet count. So Tylenol or Advil are safe drugs, but if that is ineffective, there is another medication which has been reported to help some patients called glutamine. This is a rather expensive powder that can be stirred into water or orange juice and drunk, and does significantly reduce those cramps in a significant number of patients. I wanted to mention a little bit more about the numbness and tingling, which we call neuropathy. Again, this is the only toxicity that may not be totally reversible. And if it gets really severe, it can actually interfere with balance. There are three ways a patient knows where they are in space: vision, the inner ear, and feeling your feet on the ground. You only need 2 out of 3 of those to be operational, but if your feet become numb and you close your eyes, then you don't know where you are in space and you are at risk for falling. So if you have to get up in the middle of the night and it's dark, to get up in the middle of the night to go to the bathroom, you may be very unsteady on your feet. So this is as far as I'm concerned, the most significant toxicity. And there are some things that can be done if this becomes a major problem. I'm not going to go into those details because the severe neuropathy is actually quite uncommon. Less than 5% of patients develop severe neuropathy. But there are some things that we can do to lessen that, either change the Taxol to another drug or give the Taxol over a longer period of time, or maybe even take the Taxol out of the regimen and substitute another drug. Be that as it may, it is important for you as the patient to report numbness and tingling to your doctor. Lots of doctors forget to ask about the numbness and tingling, and it's important for you to also know that this is one toxicity that may get worse for up to 2 to 3 months after the chemotherapy is over before it begins to improve, but it will improve for up through 6 or 7 months following the chemotherapy, and if there is still some neuropathy at the end of that 6 or 7 months following chemotherapy, then it's very likely that that is going to be kind of a chronic problem from the chemotherapy and something that you just have to live with. So that's kind of an overview of the chemotherapy, the initial chemotherapy for ovarian cancer. I'm sure that this will generate many additional questions for you, and you should sit down with your doctor and discuss what concerns you have and get further information about this from your doctor. Thank you.